Recording in progress. Recording in progress.
Asmita, shall we start?
Yes, ma'am, you can start.
Good evening, everyone. I'm honored to welcome you to today's session, our second in the webinar series from the outreach subsection of the IAN. Together, we are here to gather a very critical aspect of healthcare, and that is the power of education in reducing the global burden of neurological diseases. As we all know, education is a cornerstone in our effort to combat neurological disorders, which affects millions of people worldwide. By educating public, we raise awareness about the early signs and symptoms of neurological diseases, encouraging timely diagnosis and treatment. And we do this by public education. We empower the individuals to take proactive steps in maintaining their neurological health, and that's what our neurological outreach service does. Now, equally important is the education of our neurologists and healthcare professionals. By training the trainers, we say that we ensure that a medical community is well equipped with the latest knowledge and skills to provide the highest standard of care, continuous professional development, and specialized training programs which enable the neurologists to stay at the forefront of medical advancement. This is the neurology outreach subsection, and I am Dr. Bindu Menon, the chair of the outreach subsection. And we are really privileged today to have two speakers who will discuss on these two aspects of the outreach care. We are privileged to welcome Dr. Stephen Lewis, the General Secretary of the World Federation of Neurology. With his vast wealth of knowledge, we are sure that his valuable insights and experiences are going to help us a lot in framing our work flow in our sector as well. Dr. Stephen Lewis is the Secretary General of the World Federation of Neurology. He's the Editor-in-Chief of Continuum Lifelong Learning in Neurology. He's the editor of World Neurology. He's the Education Committee Chair of World Federation of Neurology, the Congress Committee Chair of the World Congress of Neurology 2023, Neurology Director, American Board of Psychiatry and Neurology, Physician-in-Chief, Fleming Neuroscience Institute at the Lakeville Valley Health Network. He's a past chair of the Neurology Residency Review Committee of the US ACGME and the Neurology Milestone Working Group of the US ACGME. He's a past vice chair of the AN Education Committee and the A.B. Baker section of Neurologic Educators AN. He has more than 7 books, 25 articles, 63 editorials, and 15 chapters to his credit. And he's also the A.B. Baker Award for Lifetime Achievement in Neurology Education from the American Academy of Neurology. We are going to deal with a very important topic, bridging gaps, addressing neurological health disparities, strategies for outreach and education for global impact from Dr. Stephen and Lewis. And then I will subsequently introduce our second speaker for today, Dr. Monica Chandy. Dr. Stephen Lewis, we look forward to hearing from you regarding how we can go on a global platform, educate and strategies for the outreach. Dr. Stephen Lewis, really privileged to have you with us.
Oh, thank you so much, Dr. Menon, and it is a real privilege and honor to be asked by you and the executive committee of the IAN to present here today. I'm going to go ahead and share my screen if I can, and get this on. Hope you can see that okay.
Yes.
Make sure it's on. Slideshow presentation. There we go. Okay. Again, thank you so much for this invitation, and here are my disclosures, which the only thing that has a direct impact is really my role as the Secretary General of the WFN and my role in the Education Committee, because I will be talking about some of the educational initiatives which I think impact global outreach. As we all know, hope you hear me fine. 1 second. Okay, great. As you all know, the recent Global Burden of Disease paper came out in the Lancet Neurology, really just stating what we all suspect and suspected all along, which is that neurological diseases represent the major impact on morbidity and mortality and outcomes throughout the world. And coupled with that, we also have now the 2-year-old of a 10-year mandate, the intersectoral global action plan on epilepsy and other neurological disorders, we call the IGAP from the WHO, really supporting the importance of neurology, neurological outcomes, local health authorities throughout the world, and making sure the neurological diseases receive the thrust, the funding, the recognition that is needed to impact global health outcomes throughout the world. So we have IGAP really supporting this global mandate to reduce health disparities, improve health outcomes throughout the world, given the vast impact the neurological diseases have on mortality, essentially, and daily our daily lives. Coupled with that, of course, we have our social determinants of health, the inequities throughout the world, in every country, based upon a variety of factors which negatively impact health outcomes. And on the right, you see a paper from on the left, you see the brochure from the WHO and their Social Determinants of Health Commission. And on the right, we see a paper from the NINDS of the United States looking at the determinants of inequalities in neurological diseases, which are separated into structural determinants of health, social status determinants of health, structural determinants of health being structural racism, structural violence and discrimination, social status determinants of health being those social class factors, gender, ethnicity, and race affecting education, occupation, income, indeterminate determinants of health, which include simply geographical changes, environmental aspects, sociocultural and environmental impacts on neurological diseases, and intrapersonal, individual determinants of health outcomes, meaning health behaviors, psychosocial factors, and disability. And last, but I don't know if it's least or not least, biological determinants of health, but of course, those are difficult to separate from those social and structural determinants of health rather than the actual biologies. But all these impact our health outcomes and are things we're keeping in mind as we create these educational endeavors. What is outreach? Before I prepared this talk, I really wanted to be sure I understood what outreach meant. So outreach in a pure dictionary term is the activity of an organization that provides a service or advice to people in the community, especially those who cannot or are unlikely to come to an office or hospital for help. Wikipedia actually had a very nice description of outreach, which is it is the activity of providing services to any population that might otherwise not have access to those services. Compared with traditional health providers, outreach services are provided closer to where people may reside and are very often voluntary. What we are doing here today is voluntary. In addition to delivering services, outreach is an educational role, raising the awareness of existing services. And as we all know, it's often meant to fill in the gap to those services provided by mainstream, typically governmental services, and is often carried out by nonprofit, non-governmental organizations. So from what I would call distal to proximal outreach can be provided by neurologists, primary care and other physicians, nurses, community health workers, and then ultimately most proximal to the patient, of course, are the families and the patients themselves. We all know this, the Atlas of Country Resources for Neurological Disorders that the World Federation of Neurology was highly involved in. We know there is vast inequity and inequality in delivery of neurological services, in particular, the number of neurologists per 100,000 population varies greatly, both from just region of the world, the highest being in Europe and lower throughout the world, including the Americas, particularly in South America compared to North America, and per based upon income status of the world. So as low as a couple of years ago, 0.4 neurologists per 100,000 in some areas to many more. So that inequality is what I think we'll harp on today a little bit regarding the educational needs throughout the world. Getting back to the WFN, what is the mission of the WFN, which is a UK registered charity and comprised of about 124 member societies throughout the world. Our mission is to foster quality neurology and brain health worldwide, a goal we seek to achieve by promoting global neurologic education and training with the emphasis placed firmly in under-resourced parts of the world. So really outreach is inherent in the mission of the WFN. Here are some of the educational outreach activities, and I'll go through some of them. I won't name them all here today on this slide, but here are some of the activities which I think are important in providing that outreach. One of the most prominent, although we can talk a bit about what the actual effectiveness of this is our WFN training centers. We have 5 training centers throughout the world currently, with more to come, and we're certainly very, very highly interested in India being in a subsequent training center. We have 2 currently in Anglophone areas of Africa, 2 in Francophone areas of Africa, and 1 in Spanish-speaking Mexico City. And these are to train individual trainees for 4-year training in neurology, as well as subspecialty training. We find that even those countries that have very, very limited neurologists, such as Sub-Saharan Africa, they still are interested not only in training generalists, but also specialists, interestingly. And these training centers are used to develop, to develop additional trainees, additional neurologists, to just make a small but significant dent in the number of neurologists impacting patient care. And again, Anglophone Africa and Francophone Africa, as well as South America. Here's some of our recent trainees: a trainee from Mali who was trained in clinical neurophysiology, a trainee from Rwanda who was trained in 4-year training in neurology. Our current trainee learning stroke neurology in Cape Town, South Africa. And that is ongoing, again, making a small, but we think significant dent in the number of neurologists throughout, particularly Sub-Saharan Africa. We have our departmental visit programs providing short 4-week stays, particularly for Sub-Saharan African trainees, to learn, to be exposed to the most modern high-level neurology throughout the world, including department training centers in Europe in particular, and this has been highly successful. And most recently, we're pleased to report we've had an Asian training center in India, and it had its most recent graduate, if you will. I believe he was from Thailand, and here's some pictures of his wonderful visit to the Postgraduate Institute of Medical Education and Research in Chandigarh, India. And 4-week visit, but I think these short visits do provide additional education enough to impact that resident's career, and hopefully his or her subsequent patients as well. The Continuum program is a long-standing program to enhance outreach and education, providing us high-level educational resources. I will also mention my conflict of interest, that I was the editor-in-chief for 10 years, but it is a high-level educational resource providing that additional education, again, hopefully impacting, countless patients downstream from that educational activity. Some pictures of the Continuum program throughout Europe, as well as Africa and Southeast Asia, and of course a very prominent program in India that I've also had the privilege of participating in at least one of the online activities. I think the other point of our educational activities, and all of our activities that many people here, and of course this one today is a great example of, is the use of virtual platforms to really enhance the geographical outreach of these educational activities. Moving more proximal to the patient, we have the primary care physician and other physicians. And one thing we are beginning to be more and more involved in the WFN standpoint, we don't have a whole lot with primary care physicians, although I think that will develop more over time. We have developed more outreach, if you will, with our brother and sister organizations in the World Psychiatric Association, the WPA, and the WFNS, the World Federation of Neurosurgical Societies. And I think these are important aspects of outreach because there's so much we have in common, particularly probably with the psychiatric organization, especially with the current emphasis on brain health, which intertwines, of course, with mental health. But we have other organizations we should consider outreaching to, and that includes organizations such as our cardiology organizations. This is a paper from the Stroke Council of the European Society of Cardiology, describing the need for more interaction with neurological aspects of stroke care, because as we mentioned, there's not enough neurologists in the world, certainly to care for all neurological disorders, especially stroke. And although this can certainly have some negative impact on neurology as a field, the question is, do patients be better off by a little more interaction between neurology and cardiology for the care of stroke patients? Again, moving more proximally, we have nurses and community health workers. And I think our WFN educational days serve some role in providing that care. So we've had well over 1,000 providers participate in our recent WFN educational days. We've had educational days on headache, stroke, neuromuscular disease, movement disorders, and others. And these are free, highly publicized, many attendees, as I mentioned. And not only are the neurologists and primary care providers, but also other healthcare providers who are absolutely welcome to participate in these important virtual days, which have no geographical limit. In addition, we have our e-learning hub, which essentially is a collection of free activities available to anyone, doctors, nurses, other healthcare providers, to look at high-level activities, which are videos, as well as PDFs and any other kind of educational format, providing neurological education throughout the world. So this is available to really any level of neurological worker, healthcare worker involved in the care of neurological patients, hopefully impacting health outcomes via improving educational outcomes. Our WFN publications, including the Journal of Neurological Sciences, and many of you know our free newsletter that I happen to be the editor of, World Neurology, provides lots of education, information. Just another example, a few years ago, as you all know, the mucormycosis epidemic that occurred during COVID, very quickly publicized through World Neurology, and hopefully impacting the care of these patients and the outcome of these patients, and the really recognition of this quite striking comorbid disorder. Finally, moving more proximally, we have patients and families, and at our World Congress of Neurologies, we've had for about 10 years, maybe even longer than that, a patient day devoted to education of patients regarding neurological disorders, and frankly, the importance of neurologists. We're talking about 100 or 200 people, so we're not talking about impacting many patients, but every little bit helps. And this is the example of the information that was provided to patients in person at the WCN Patient Day in Montreal on gene therapy and keeping brains healthy, cultivating resilience, the role of AI, or the potential role of AI in neurological disease, and so on. World Brain Day is, I think, a really good example now of the importance of outreach. So World Brain Day is July 22nd of every year for the past 10 years or so. That particular date actually commemorates the first day that the WFN was created in 1956. Each year there's a different theme, but the recent themes have been related to brain health. This year is on brain health and prevention. And due to the many activities throughout the world, this is a educational effort with direct outreach effects on patients. And of course, we all know the remarkable activities that have occurred in India. It's no secret that although there are wonderful activities throughout the world, the Indian activities have been tremendous and have impacted, I think, directly, certainly the education of patients worldwide on neurology, neurologists, neurological disorders, and now brain health and again, hopefully impacting outcomes. So we'll harp on that, or we'll talk on that just at the very end here today. And of course, we have Dr. Menon and other leaders throughout the world who have remarkable activities, directly outreaching and directly impacting and speaking to and working with, thousands of patients, again, hopefully, and most likely affecting outcomes. Which brings us to technology, again, an article from Dr. Menon of the use of technology to impact epilepsy care in particular, but other neurological diseases as well. And technology plays a significant role. Here's another article on telemedicine devices and telehealth and neuromuscular diseases. Came out just in the last issue of World Neurology, showing how we can actually provide, iPhone, iPad, other technologically based devices for patients to be monitored for their disease from afar. So, example of educating patients, educating providers, using technology to impact the recognition, the diagnosis, and the ongoing monitoring of neurological disease, in this case, myasthenia gravis and other neuromuscular diseases. Telemedicine is changed, as we all know, what we do. Example in Nepal and also in rural areas of the United States. I do want to mention that where I practice, which is a area of Pennsylvania about an hour from Philadelphia, we have patients who just 30, 40 miles from our center, our massive medical center, we have patients who can't access us. They have limited resources, limited abilities to travel. So as close as 30, 40 miles, even in my high-income area, patients are limited by access. So we have teleneurology has made a significant dent, but we're still limited by the fact that physician seeing that patient still needs to, it's still a one-on-one visit. So telemedicine still hasn't totally impacted the significant issues we have with access to patients, even relatively short distances from major groups of neurologists. We'll talk a bit about really not an educational thing, but mobile stroke units, which is another outreach concept, again, directly impacting the patient. We're lucky enough to have had a mobile stroke unit at my own institution. Here are some mobile stroke units elsewhere in the United States and throughout the world. There are about 30 mobile stroke units throughout the world currently. And here you can see, at least from about a year ago, the distribution of mobile stroke units, including one listed there in India. And in my own region. So mobile stroke units are an example of using telestroke, which of course we're all aware affects access to stroke care, improving door-to-needle times in patients who otherwise wouldn't be able to get that access so quickly. But here, this is access directly at the patient's home or work, where the mobile stroke unit is brought directly there. So that's an example of real outreach to the patient with a mobile stroke unit. And the question is, does a mobile stroke unit with a CT scanner in the unit, with the neurologist perhaps 50 miles away, providing that thrombolysis to the patient at their home? The question is, does that kind of outreach actually affect outcomes? And this is the BEST MSU trial a couple of years ago in New England Journal of Medicine. And here, this study showed that in areas served by the trial with mobile stroke units, patient who received emergency care within 4.5 hours after stroke onset had less disability on a utility-weighted scale at 90 days with MSU management than with management by emergency medical services alone. So an example of a very direct outreach program to a patient, which is a mobile stroke unit going to the patient's home or work, the physician miles away, telling the providers at the scene to give the thrombolysis that actually there's actual evidence that that actually affects patient outcomes. There was a whirlwind tour of outreach, thinking of outreach as educational outreach, as educational outreach to providers, educational outreach to neurologists, to nurses, to other professionals, as well as direct patient care outreach, for example, with mobile stroke units. In my summary is that neurological disorders are the leading cause of disease burden globally. We're all aware that health disparities and inequalities are ubiquitous. Improvement in neurological outcomes is a priority of the IGAP of the WHO. Unfortunately, there's a worldwide shortage of neurological providers, and outreach is critical in enhancing neurologic health outcomes. Outreach includes education of providers and patients. Importantly, the success of any of our interventions, including education of neurologists and other healthcare providers, and our increase in neurological providers, should be measured by assessing disease outcomes directly. And last but not least, neurologists should be at the forefront of these outreach and educational outreach endeavors. Thank you very much.
Thank you. Thank you very much, Dr. Stephen Lewis, for that wonderful, I should say, whirlwind of, as you rightly said, neurologists should be on the forefront, and it includes several aspects, not only patients, providers, neurologists, physicians, caregivers, community health workers. So when we talk, if we can take some questions, we have some here, and this also is streaming live on the YouTube. So I have some couple of questions which have been sent to me to ask you. When we are training a non-neurologist to provide quality neurological care, how effective it is, and at what point, till what point we should be training them? Should they be one who should be identifying the diseases and sending them to the tertiary care, or they should be trained in a way that they should be equipped to provide the first aid care? First aid means the emergency care, and then take it from there.
So that's a very good question. I think it's very difficult to think about training. Talk about other physicians. We can't create neurologists out of other physicians. We have our own way that we think, the way we deal with patients. So it's important to recognize the mindset, if you will, of other providers. So I think the idea of making a neurologist out of a non-neurologist is probably not correct, but making sure that they recognize when the patient has a neurological disease, recognizing how to initially treat neurological diseases, but critically recognizing when that a patient needs a neurologist. Of course, there are countries where there may be one neurologist per, in an entire country, so that may not be feasible, and hopefully over time telemedicine will play some even increasing role. Many other specialties, if you will, internal medicine in particular, is very algorithmic, and we have to recognize that. That's not a negative, but it's true. But luckily, lots of what we do now is becoming more algorithmic, like stroke care. I think that's is much more similar now to internal medicine than it was in the past. So very algorithmic. So that can I think be trained, which is why that interaction with cardiology may be of significance. But some of what we do can't be copied, if you will, but much of what we do can, but at least that initial diagnosis, that initial recognition, and quick referral, if feasible, to a neurologist would be optimal.
Thank you. So I suppose it should be recognition and responding should be the key where they should also be trained. And there's another. Yes, now we are all on a digital world, and virtual platforms have become very common for webinars and knowledge exchange. but how these virtual platforms are good in conducting training sessions in neurological care. Have you found that to be as effective as a physical one?
That's an excellent question. I still think in person is best. And now this is an example where it would be impossible to be in person, and it's wonderful. So it's a very, very, very close second, the virtual, very, very close second. And certainly there are there's no question that the virtual has allowed all geographical boundaries as we see today to be overcome. So they live hand in hand. So the virtual is here to stay. It's the silver lining. We mention all the time the silver lining of the COVID epidemic is how virtual care, but also virtual education became ubiquitous and will be here to stay. No question about that. But it has not undone the need for in-person. Even in my own institution, we allow for virtual participation in grand rounds and case conferences, but walking down the hall taking place and sitting in that conference room is still, at least anecdotally, it seems to be better educationally, if you will, to be there. But they live hand in hand. They're overlapping Venn diagrams, and it's pretty remarkable how virtual has really improved global education, but has not totally undone the need for in-person. I had the pleasure of being at the Indian Academy of Neurology meeting last year in Madurai, and being there in person, just there's no way that could have been. It can be equated to the virtual. So hope I'm answering your question, but.
Yes, absolutely. Absolutely. There's no yes and no to that question. And Dr. Gagan, you have a question there.
Yeah, no, thank you, Steve. Thank you, Bindu. Thank you, Steve, for the excellent overview of what outreach should be. And this, I just remember that a friend of mine's, Arjun Sen, and myself, we had gone to Zimbabwe some time back. And there was one neurologist, and what we felt on landing in Zimbabwe, that we had actually tripled the number of neurologists just by landing in that country. And that was a few years ago. So, yeah, I think what Steve has said is it depends on the context, it depends on the country. And fortunately, we in India now have a fairly good number of neurologists. So that's something. But then there are countries where there's just a single neurologist, and the first point of contact for most people with neurological disorders might not even be a doctor, might actually be a nurse. So I mean, that's perhaps the beauty of the situation. It's so varied, and so I mean, I'm actually, the most interesting part is in well-developed countries like US, still, I mean, you talk about outreach. So that's something very interesting, and I wonder what your thoughts about that.
Yeah, no, it's remarkable. We have countries that, as I mentioned, have one neurologist for an entire country. We have countries like, and of course, India is very developed in terms of neurology. The U.S., I have 35 neurologists in my own institution, as opposed to one in a whole country. But despite having 35 neurologists in my institution, access is an issue. We have patients who have to wait 9 months to see a neurologist, even for their migraine, if you will. So we need, that's why thinking of outreach as a outreach, I'm doing a lot of thinking when I was asked to give this talk. What does outreach mean? And outreach means enhancing care, forgetting the definitions, enhancing care through access, through education, through recognition, through diagnosis, through so we're all involved in access, whether it's neurologists, primary care providers, nurses, other sorts of community healthcare workers, and uh, but I think our role as neurologists is to make sure that that care is and that recognition, care, management is appropriate. We are the leaders. We are the experts. So we have to make sure that whoever is providing that care is providing appropriate care. So that's where I think boiling this down to education is really a nice way to think about it. Even if we're not always providing that actual care, we must be educating those people, but also recognizing the fact that in some cases neurological care can only be provided by neurologists. But it's a very, very interesting dilemma, if you will.
Thank you. I suppose there's another one single question. How effective do you feel is that patient and public involvement should be there in development of any of the, let us say, the workflow that we create for patients, not really guidelines? How much should we be including patients in the committees?
That's a very interesting question. There's a push in the United States in particular, but I think throughout the world, to have there be a voice, a patient voice, a community voice. I think the other word is public, a public voice in our organizations, our accrediting organizations, our certifying organizations, and so on. So that's still being developed. I think the answer is I don't know. I think we always must listen to patients, must listen to the public, be aware of their wants and needs. Of course, we're all public members. We all have family members with disease or even our own neurological or other diseases. So we are all both providers and members of the public. But recognizing that public members who aren't also physicians should have a voice, should have a role is I think good. How to mandate that is difficult, but there's no question we should always be listening to needs, because that's really what it's all about. Thank you.
Thank you. Thank you so much, Dr. Lewis, for that wonderful talk and the great interaction. Thank you. Be with us with Dr. Monica Chandy also has a similar talk where she is going to enlighten us in the next couple of minutes. Before that, on behalf of Indian Academy of Neurology and as chair of Outreach Subsection of Indian Academy of Neurology, sincere thanks for joining us today for this outreach webinar section.
Thank you, Bindu.
We have a second speaker for today, Dr. Monica Chandy. She is our robust member of the Outreach Subsection. She is presently the consultant neurologist of Holy Family Hospital, New Delhi. And she's part of the ECHO program, the Extension for Community Healthcare Outcomes, which was started by Sanjeev Arora at the University of New Mexico, Albuquerque. Dr. Monica, she's going to talk on educational approaches to improve neurological health awareness.
Unmute yourself, ma'am. Yeah, this is like a really, really hard act to follow because I am a literal nobody. Dr. Stephen Lewis, extremely impressive. You have given us a panoramic, the entire worldview. Thank you so much. I'm going to touch upon a few educational approaches to improve neurological health awareness. And it's interesting, Bindu and Sadish, since you're the ones who call me, the etymology of education was used in the 1530s in the context of child rearing, as well as training of animals from French education. Systematic schooling and training for work with a lot of imperatives like sit, stand, do this, do that. And William Godwin in 1791 said, all education is despotism. I'm sure that's definitely not what you had in mind, Bindu. we have obviously a loftier view of education as well as its close new counterpart, learning, which is we think of it as empowering, we think of it as dispelling ignorance, we think of it as something that will give agency, bring about societal good. Next. Yeah. You know, our own forerunners thought that epilepsy was either divine or demonic. So I guess our own community fraternity needs education. It wasn't until Hippocrates who was the first one to separate epilepsy from the divine. And the next is this apocryphal, not sure, but there's this poor person, maybe with epilepsy, whose head is on the anvil and this huge hammer on his head. Things are not too different even now. I think it's around the world. We have all sorts of stories and ideas. If you go to the next one, Asmita, in a little village called Surajpura, there is this famous man. He's called the Kida Baba, or the worm man, where the mother worm of the cysticercosis larva of a patient with neurocysticercosis has the worm delivered from his brain via the nostril. Definitely a sleight of hand and not science. Warm pigeon blood with revitalizing power is smeared on paralyzed limbs. Milk solids, khoya by the kilo, is placed on head to reverse paralysis due to stroke. Persons with epilepsy, their first port of call is the Godman, and quite often, jhad phuk, they are summarily thrashed with a broom. What is the landscape? I mean, the fact that we are discussing various educational approaches, multi-pronged approaches, is based on the premise that there are huge disparities across the world, across healthcare. Today, of course, we're specifically talking about neurology. The low neurologist to patient ratio is probably, you know, even though we have many neurologists, we have extremely talented, very well-trained neurologists, but we are clustered in the urban areas. We still have a tertiary quaternary mindset. We don't really think of the community so much. And I'm so glad there are role models like Bindu Menon and Stephen Lewis and a bunch of others who think of the community, because that really is where we ought to be moving from the ivory towers of our tertiary hospitals. We need to get into the trenches. And this persistent paradigm that, you know, we look at tertiary level as the only one that can provide excellent care. We need to create more specialist hubs, but not at the cost of missing basic primary health care. And that's a point of education for us neurologists. There's a huge gap that cannot be overstated. There's a huge gap in the neurologist to patient ratio. There's a huge gap in expenses. It's a mortifying fact that one of the highest out-of-pocket expenditure is in our country. Patients spend 62.5% of their own money, which means they're not insured, and the money doesn't come from the government. And these are the ones who are most vulnerable to the newer corporatized healthcare systems. There's a huge gap in access, rural, remote, urban, poor, all of them. The next, please. And then there's not just a triple whammy, probably multiples of triple. There's low levels of literacy, poor health literacy, and then there's poverty in the most populous country of the world. Next. And yeah, this is really awful because the lower and middle income countries have a higher stroke mortality. Just an example, these are anecdotal, of course, but there is a patient who had a stroke. The ICU admission was unaffordable. He went home, he had a swallowing issue, he aspirated and died. And there was another patient, a driver, who was earning about 20,000 rupees a month. He got admitted to a corporate hospital and had to pay for less than 12 hours of admission, 1 lakh rupees for a small vessel stroke from which he recovered in a few days. So the idea is that we have to collaborate. We have to build safe networks so that patients can come from their homes, their proximal locations, we manage sometimes where they are, and when necessary, come to the big cities. So we need to have, in a city, for example, if we had a city-based command center, we had a dashboard of bed availability, we had a free ambulance service, things would be so dramatically different. And I think we need to educate the powers that be, the policymakers. And if we explain to them the problem, the solution, and likely publicity and political returns, we might have them on board too. So the goal of education is empowered awareness for patients, their families, and creating easier access. Because if we make them aware and do not provide access, that's like Marie Antoinette, a reversal of a flavor of that, saying, can't have bread, eat cake. So the onus is on us, physicians, to provide easier access pathways, to make sure that care is affordable, so that all of these can result in improved outcomes, societal good, and eventually a global impact. Next. It thrills my activist soul that the NINDS is now looking at determinants of inequities in neurological disease. Next. And education programs, it needs to go beyond the adrenaline of clinical excellence. Neurologists must understand hitherto unfamiliar aspects of healthcare, social determinants, patient rights, pricing, supply chain, low-cost affordable solutions, no-frill treatment, and acquire skills to navigate between urban tertiary as well as community outreach programs. And these things will not come unless those of us who are more senior are intentional and create these programs. We demystify neurology, we unpackage, we train, we upskill, we use flipped classroom, we do hand-holding, mentoring, repeated practice, simulation learning, standardized protocols. All of these will have to be included into what has been traditional highbrow neurological training. Next. And again, this very interesting article, Neurology Education in 2035, is definitely going to include all of these: health humanities, diversity, equity, the things that Dr. Stephen Lewis spoke about. And that is extremely heartening. Next. And I'm just wondering whether we can flip things around instead of creating more and more stroke centers, specialist hubs, which are excellent. And I think maybe we need to do both simultaneously. There will be a population that requires that demands that. And when those excellent options are available, I think we have to work hard to provide those. At the same time, we need to think that excellence doesn't always mean tertiary or quaternary care. Excellence could also mean maybe creating a village stroke room, because this patient otherwise is either going to die or be paralyzed or get an aspiration pneumonia or have a bleed from uncontrolled blood pressure. So what if we flip things around and we say, let's create some village stroke rooms where maybe after the stroke is completed, at least his basic blood pressures and glucometers, ECG machine, and all of these, oxygen cylinders, we need to work towards these as well, because otherwise community outreach, the promises of community outreach would be empty. Next, please. And so in the primary health center, especially those patients who are stable, because we also know that it's a minority of patients who really need tertiary care. At least those are the figures that I'm coming across as I interact with multiple centers. And so there is the case made for a village stroke room. The stable patient, mild neurological deficit, safe to treat. And I think the safety factor is where we come in as a network, because if we are able to support that junior doctor or that solitary neurologist out in the boonies, it will transform healthcare. If there's a progressive deficit, if there's a worsening condition, then shift along an escalating referral pathway. We all know that in India, we don't have a rational escalated referral pathway. So patients cross zigzag, crisscross, all of the time, spending money out of their pocket, being completely lost without agency in the healthcare system. So I think community neurology will have to include all of those, improving more comfortable, patient-friendly, pocket-friendly pathways. Next. Yeah, and where CT is not possible, just assess, stabilize, watch, maybe even discharge in a few days. Next. I interact with this place in Manali, which is in Himachal Pradesh, and there is actually an American-trained emergency physician who looks after stroke patients. And she says our stroke protocol is actually very basic. They have a CT scan, they have teleradiology, they get a report, but most of the time is just aspirin, blood pressure control, and glycemic control. They don't have an ultrasound machine. They don't have an echo machine. And when I looked at some data some years ago, even across the UK, the change in management after a carotid Doppler is not huge. So maybe we can stick with the basics where nothing else is possible. Next. Next. Yes, to educate trainees, maybe junior doctors, maybe young neurologists, maybe even mid-level providers, cognitive heuristics. And I've found recently that, the repetition, the mnemonics, red flags, green flags, that helps even a senior person like me to have that on the side of my notes. Mnemonics like pound and snoop. So, you know clearly that this is a primary headache, and it hastens, it speeds up the process. And so there is an optimal use of resources. So we don't have a glut of investigations where those may not be required. And there is a rational management with good education. Next. Ethics is another thing that we need to start teaching. And I don't think this should be an option, because ethics is necessary, and leads to right praxis. And this is applicable to every discipline. This is, of course, completely counter to the market economy which currently prevails and which drives healthcare. Healthcare in India, as in a lot of places, has become a commodity. And so the need for ethics as part of the core curriculum for neurological training. Next. Next, Asmita, please. Yes, and this is an old favorite, Rodolphe Virchow. Medicine is a social science. Politics is nothing else but medicine on a large scale. And therefore, I think we train more and more physicians, more and more neurologists to become physician attorneys who stand up for the rights of their patients. Next. Yeah, the power woman on wheels, that's Dr. Bindu Menon, the chairperson of the subsection. Kudos to you. Many others who led the way, fantastic role models from yesteryears, like Dr. Shah, Dr. Gauri Devi. Huge female bias, actually, because I know of only female neurologists and few men, maybe. And there is one who goes chugging on a train across the country. There's somebody else who visits really inhospitable locations. And then I think we are all familiar with the Zambia model, where the Johns Hopkins group, through grants from the WHO, have actually started neurology training in Zambia. So that's an example of transnational collaboration, transnational education. Next. And I think we should also educate the rich, because it's possible that once they know what their money can do, when we explain to them the disparities that exist and what a few simple measures can bring about, they might actually be interested in a sponsorship or a cross-subsidy model. So that's another group that might be educated. Next. This is the success story from Jharkhand. Basically, again, community health volunteers, they go identify the patients. Then there are itinerant visits, free medication, follow-up by the local. They call them quacks, they call them registered medical practitioners, but really that's a euphemism for people who are completely untrained, and yet they are the first port of call, and for the major part are accessible and don't do too much wrong. Next, please. Focus discussion groups in the community. I'm sure Bindu does that. I do that when I visit as well. School children and school teachers becoming health ambassadors, another form of education. Next. Friday afternoon, every Friday afternoon, I travel to the Red Corridor. The Red Corridor is that area, areas of Maharashtra, Chhattisgarh, Madhya Pradesh, Andhra Pradesh, which is home to people part of the Naxal movement. So every Friday afternoon, I do a digital clinic. And the little black box that you can see in front is the mobile phone. And they listen to the oracle from Delhi. No, just kidding. But actually, it's a fairly interactive discussion. The junior doctor or a physiotherapist presents the patient. The gentleman is the EEG technician. The investigations are uploaded, and it's a fairly satisfactory, comprehensive neurological consultation for about 200 rupees, which per patient, which then is given to my parent institution, which allows me this time. And I must say that headaches, strokes in the ICUs, all of these patients are managed quite well. Where I struggle are the myelopathies, the neuromuscular diseases. Next, please. Yeah, and that's the UMRI model. The majority of patients are poor. They're either poor tenant farmers or construction workers. They're not able to access healthcare in the larger cities. And so this hospital, which is 70 years old, has been doing great service. They have an EEG machine, a CT scan, an ICU. And what they've done in the last couple of years is they've got specialists on board who are available for digital clinics and some who visit on and off. Next, please. This was a very exciting part of my life, getting involved with the ECHO, Extension for Community Healthcare Outcomes. Dr. Sanjeev Arora from the University of Albuquerque, probably Dr. Stephen and others know him. A disruptive innovation where all teach, all learn. Otherwise, a lot of education tends to be unidirectional. There was democratization of knowledge. And basically, their motto is give away knowledge, share expertise. It was like a digital grand round. The only disadvantage I found of this was that because of the HIPAA restrictions, one didn't have patience. Sorry, can you next, please? Yes, and these are the spokes from Holy Family. You can see multiple locations around northern India. A lot of friendships were forged. And in addition to this asynchronous clinic, we were part of a WhatsApp group, and I was available for pro bono consultations. Next. That's the picture. That's like, and remember that this predated Zoom. So it was like very, very exciting. Now, of course, Zoom is so commonplace. Next. Yeah. So Tea Garden Hospital, doctors in Assam, Bengal, rural Uttar Pradesh. Arunachal Pradesh is an interesting and a model that Indian Academy of Neurology should look at because they have non-communicable disease clinics in every district. And so upskilling those physicians would help reach Arunachal Pradesh. At the moment, they don't have a single neurologist. They only have people who visit from out of state. And those are usually private places, so those are expensive. Next. And the effectiveness of mobile technology, Dr. Stephen touched on that. So let's skip that, please. Next, Asmita. Yeah, we must invest more in the ASHA workers because they could be our frontline workers, even for neurological illnesses. Next. Yeah, as we all know, person from the community, high acceptance, they can be a trainer, coach. And if we teach them and they also do these adult learning models with focused discussion groups, I think they would be able to advance neurological care in the community. Next. They could at least be follow-up. This is an urban outreach. That's the ambulance that goes out from the hospital where I work into the rural, urban, poor communities. And we have a healthcare assistant program, which is free of cost. It's for 3 months. They learn the basics of running around the hospital, helping patients, but One of them has actually become full-time, and so she's there in the neurology outpatient. So these people, as we multiply those numbers, they can help. They can be agents of change. They can counsel. They can help the patient navigate the system. They can explain the prescription, make follow-up calls, and send reminder messages, all of which my healthcare assistant does. Next. Where hence, like Dr. Gauri Devi said many decades ago, neurology should become more public health neurology. My dream and my swan song is to build a community neurology fellowship. I know there are concerns for excellence. I know there are concerns about diluting. But if we look at the present scenario, I actually have seen patients who have been jammed in their muscles by technicians who are not trained, but they are sitting in big urban centers. So let's recognize the reality and know that a pragmatic approach might be the way to go. If we can create a community neurology fellowship for post-MBBS doctors, for child specialists, because the fact is the bulk of neurological diseases, at least in our country, are managed by non-neurologists. If we can prepare a primer for practitioners, create linkages through IAN, and have hub and spoke models across states. Yeah, I'll stop now. Thank you so much.
Thank you so much, Monica, for that wonderful talk. As we all know that in India, we had this outreach problem where we had this ignorance, where there is a gaps, and there's gaps was of gap of awareness, gap of ignorance, a gap of distance, patients not able to travel, the gap of treatment. So there's so many gaps of that, and it is really difficult for us to address each one of them. And that's the reason why we came up with this outreach subsection to sort of dwell with what are the challenges which we could have. And as was suggested from you earlier about the community neurology fellowship, as you would also be knowing that we have floated in a questionnaire to all the neurology members across the country, and we're going to have some sort of information from them as to what, how much, where, and how what sort of aspects they are dealing with and what are the challenges they are having. So probably we would have a time frame and would have a framework of how to go about it, and probably in a couple of months should be able to address that issue as well.
Thank you. That's wonderful to know. Yeah.
That's why. So I also ask and urge, I should say, all the neurology members who have joined us. There is a questionnaire which has been floated to you on the WhatsApp as also on the email, so that to kindly reply to that, fill up a questionnaire. It's just a 2-minute questionnaire, but it will give us a lot of insight into what's happening in the neurology community and how much our neurologists are reaching out into the community. Thank you very much, Monica. Thank you very much, Dr. Stephen Lewis. Yes, and thank you. Thank you very much.
Thank you so much for this privilege. Yeah, thank you.
So each and every delegate who has participated, thank you very much. See for more webinars in the near future. Keep watching our site for more information. Thank you very much.
Thank you.
Asmita?
Yes.
How many were there, Asmita? I couldn't see the participants.